Welcome, everybody. Hello, everyone. Welcome to Hashimoto's Awareness Monthly Conference Call. My name is Fabienne Hamans, and I'm the co-founder of Hashimoto's Awareness together with Pearl Thomas. Pearl, you want to say hi?
Hi, everyone. Welcome. It's so good to be here tonight.
And we also have Joseph Campos, one of HA's directors.
Hello.
Hello, Joe. And as most of you know, Hashimoto's thyroiditis is the most common autoimmune disorder. And tonight, we will be discussing conditions affecting women. Living with Hashimoto's presents a unique challenge for women wishing to conceive. Together, we will explore the unique considerations surrounding fertility, pregnancy, and postpartum for women who want to thrive and have healthy babies, even with autoimmunity. Our vision for tonight is that you all walk away from this conversation with an actionable information to start improving your health, overall health, and fertility. We will have a 35-minute lecture followed by an opportunity to ask any question you may have on the topic addressed. So before I introduce you to Dr. Jolene Brighton, our keynote speaker tonight, let me share a few things about who is she being in the world. Dr. Jolene Brighton earned her doctorate in naturopathic medicine from the National College of Natural Medicine. She received her bachelor in nutrition science and completed graduate coursework in molecular nutrition at Cal Poly San Luis Obispo. And she has an extensive training in integrative women's health and autoimmune disease management. She's also a holistic pelvic care practitioner. Having developed Hashimoto's following the birth of her son, Dr. Brighton is a strong advocate for the Hashimoto's community with special emphasis on fertility, pregnancy, and postpartum thyroiditis. She is the author of the book Healing Your Body Naturally After Childbirth, The New Mom's Guide to Navigating the Fourth Trimester, and she is launching a new program aimed to support fertility and healthy pregnancy for the Hashimoto's community. Dr. Brighton, we are so excited to have you with us today.
Thank you. I'm so excited to be here. This is, as you read in my bio, this is a topic that's really close to my heart. So I want to dive in tonight. I've got a lot of great information to share, but to start, I would like to start by just sharing a little bit about my story and a little bit about how I became so passionate about this topic. So, back when I was in my first year of medical school, I had the opportunity to study under Dr. Karazi, and he was teaching a thyroid seminar, and it really opened up my eyes to the world of Hashimoto's, how complicated and fascinating the condition is, and how just utterly mismanaged it is in the conventional paradigm. And so that really began my journey with Hashimoto's. It wasn't until fast forward to the birth of my son that I myself developed Hashimoto's, and it was a great learning experience for me. And I'm very grateful for the opportunity to have gone through what every patient with Hashimoto's has really gone through in seeking help from a practitioner. I slowly developed over time a lot of the symptoms of hypothyroidism that a lot of people on this call can identify with. I was losing hair. I was developing brain fog. I was really tired, sleeping 15 hours a day, having extreme joint pain, and going from doctor to doctor, telling them about my situation. Now, I myself was a doctor at the time of developing this, and I had this belief that I should not doctor myself. And it's true, I'm not objective enough to look at my condition and be very honest about what might be taking place. So I sought help from colleagues, and I sought functional medicine practitioners and naturopathic practitioners. I went conventional medicine route and heard over and over that, your symptoms, they're just part of being a mom. This is part of being a mom, and it's probably because you're stressed and you should get some more sleep. And it wasn't until I fell asleep at the kitchen table after sleeping 15 hours that my husband came and woke me up, and he proceeded to relay back to me all of the symptoms. And he said, I don't understand, your mood's low, and you're so fatigued, and you don't have your brightness anymore. And he started listing off all these things, and in that moment, it clicked. And I was like, I have hypothyroidism. And I ordered labs, and sure enough, there it was. And it was something that there was multiple times of doctors ordering labs, not getting things right. And we're going to talk a lot about that, about how do you work up a Hashimoto's patient, and how do you look at women who have had a baby who, potentially have Hashimoto's. I'm really grateful. I struggled as a patient. And so I know this world from the practitioner perspective and from the patient perspective. And so when a woman comes to me and she says, I'm having all these symptoms, and everyone says it must be in my head or my labs are normal, I absolutely dig deeper with them. And that's what we're going to do tonight. We're going to dig a little bit deeper. So, I'm assuming that most everyone is familiar with what the thyroid is on this call, but I definitely want to go over a little bit of the physiology with that, just so we can understand about lab testing and different things that we're looking for. So the thyroid, it's a little butterfly-shaped gland that sits on the front of the neck. And really, that little gland is responsible for so much in our body, but that's not where the actual signaling for the thyroid begins. So it actually begins in the brain, and it begins in the hypothalamus, but most commonly patients are having measured what's coming from the pituitary, which is the thyroid-stimulating hormone, also known as the TSH. It's the most favorite thing for doctors to run, and nothing else in a lot of cases. So TSH is what the brain says to the thyroid, and then the thyroid responds by secreting T4. There's a little bit of T3 that comes from there, but mostly it's T4 coming from the thyroid gland. That T4 is then sent out into circulation, and it's converted to its active form, which is T3. And that's happening in various tissues out in the periphery, the kidneys and the liver and the gut being some of the primary tissues where that happens. And then that hormone has to travel to the cell. Now, every cell in your body has a receptor for thyroid hormone. That's how you know it's really important. And when it travels to that receptor, you need different nutrients in place, and there's different factors that can actually impede the ability of the cell to get the thyroid hormone in there and being able to utilize it. And, two main nutrients that can be an issue for people are vitamin A and vitamin D. And both of those are absolutely necessary if we're going to utilize our thyroid hormone. And so I explained this whole pathway because it's important to understand, why we're testing these things, but it's also important to understand that there's a lot of points where thyroid hormone can get disrupted. Sometimes it's the brain, sometimes it's the thyroid, sometimes it's an issue with conversion, or maybe we're having an issue taking it up on the cellular level. And, that's why I think a lot of, practitioners in the Hashimoto space, they advocate so hard for all of these lab tests to be done. And it's something that I feel like in our space, as naturopathic doctors, as functional medicine practitioners, we really understand these labs well. And, in the conventional model, they're not taught all of these nuances that take place. And so I just like to say that because, sometimes when your doctor doesn't want to order labs, it's because they don't know how to interpret them, and I wouldn't blame them for that. But I'd like to go a little bit further and talk about, some of the things that we see in terms of thyroid hormone as it relates to fertility and to pregnancy, and really start to dive into this topic. So we know that in a woman who has not even necessarily a low-functioning thyroid, but maybe she just has suboptimal thyroid levels, we can start to see irregularities as it affects her menstrual cycle and her fertility. We can see there's anovulatory cycles, which means that she's not releasing an egg, so she's not ovulating. We can see defects in the luteal phase, so that's the second half of the menstrual cycle, when your progesterone should be really rising, and if they're at its highest, we can see that progesterone may actually be deficient, or there might be a relative estrogen dominance taking place, which is common in Hashimoto's patients. We also see fluctuations in sex hormone binding globulin, and that's a protein that grabs onto our sex hormones. And we can see that when we see those sex hormone binding globulin fluctuations, there's also thyroid binding globulin fluctuations. So we're getting carrier proteins that are grabbing onto our hormones and not allowing them to be free. But the overall take-home is that if you don't have optimal thyroid function and optimal thyroid hormone getting into those cells, it's going to interfere with your reproductive hormones. And I don't want to paint like a bleak picture of things. So if you're thinking like, oh my gosh, like is this going to be kind of a doomsday talk? It's not. We're going to be heading into things that you can do. So sit tight with me. So the other aspects that we have to look at, so even if a woman does conceive, so let's say we get your thyroid optimized, but you do become pregnant. Well, in pregnancy, it's also very important to be monitoring a woman and looking at her thyroid hormone, because that thyroid hormone plays a really crucial role in babies' development. We know from the research that women who have had low free T4, so that's the available T4, in early pregnancy, they found that it was associated with impaired psychomotor development of children. And I want to point out that this is very specific to T4, and the reason for that is that T4 has the ability to cross the placenta and actually enter into baby's brain. Most people listening to this call are probably thinking, but T3 is why I feel good. Yes, T3 is definitely why mom feels good, why patients feel good, because they're getting that active hormone. But T4 is absolutely necessary in baby's growth and development. And this is a place where I think things start to get a little bit shaky for women who have Hashimoto's. A lot of doctors will understand that you have to optimize thyroid hormone preconception, so for a woman to become pregnant, but not many will actually know the nuances of how you should follow a woman through pregnancy. They absolutely know that, there's an impact that having low thyroid or high thyroid can have on baby, but they're still not quite sure of, what are the guidelines and what should we be testing and what are the different things we should be looking for. So I want to talk now a little bit about the lab testing that I like to run and that I recommend patients have done. And I also want to say that this is going to be something we look at preconception, and I'll point out when we're specifically thinking about pregnancy. And then a lot of these labs I also run in the postpartum phase as well, because that can be a time when we see flares in autoimmunity returning. So I'm going to talk about some very specific labs, but I just want to let you all know if you're not writing down labs and you feel like this lab portion is a lot of information, I actually made a handout for you. And you can go to my website, which is drbrayton.com/labs, and my last name is Brighten. And so you can actually get a free download lab information that I recommend. So you can just listen the first pass and then read up on it later. So as we talked about, the TSH, the thyroid stimulating hormone coming from the brain, is one of the favorite markers for doctors to measure thyroid function. And from the research, what we come to understand about the TSH is that anytime we see levels of 2.5 or higher, we're looking at a possible case of infertility secondary to thyroid hormone function. So if you're a woman and you'd like to conceive and your TSH is 2.5 or higher, it's actually recommended that you begin thyroid medication. And that is to optimize your fertility, but also to protect baby. The TSH in the first trimester should be maintained under that 2.5. So it can hit 2.5, but we don't want to see it sneaking up above that. So this is once you become pregnant. When you get a positive pregnancy test, it's recommended that every 4 weeks from that pregnancy test, you're having your thyroid lab monitored. And I really want to point this out because when it comes to thyroid hormone, if you're needing to take thyroid hormone exogenously, so you're taking a medication, or you're someone who's been kind of on the fence with, should you take a medication, should you not? This is absolutely something that should be monitored very closely because about anywhere from 20 to 50% of women will require an increase in their medication dosage to meet both mom and baby's needs. And again, that T4 is very important for baby's brain and baby's development overall because baby's going to be dependent on your thyroid hormone well into that second trimester. And, I also want to point out that in the preconception phase, some experts do feel that it's beneficial to actually put moms into a little bit of a TSH suppression, so give them a higher dose of thyroid hormone to drop their TSH in order for them to basically compensate for when pregnancy occurs. But the reason why I want to point this out is because caution should always be used with this because we see negative outcomes on baby when thyroid medication is too low but also too high. So I just really want to point that out because sometimes some doctors, they're they say, oh, well, we're just going to give you a higher dose and suppress your TSH, and then you'll get pregnant, and then everything will be fine. That's not necessarily true, and you want to work with someone who's experienced in that and who is going to monitor you for every 4 weeks. So if your TSH is found, let's say everything's fine, and you then become pregnant and your TSH comes back at 3, the Endocrine Society actually recommends that a dose of 50 micrograms of levothyroxine is started at that time. And a lot of the research will point to doing whatever you can to get that TSH down as quickly as possible because we want to protect baby. And then as you progress through pregnancy, we watch that TSH to be less than 3. So there's a little more wiggle room in terms of that TSH allowing to be a little bit higher. And that has to do with the fact that your baby is now producing their own thyroid hormone as well. So for the first half of the pregnancy, every 4 weeks, having your thyroid, and I recommend a complete thyroid panel being monitored. And then once you reach 26 to 32 weeks, of gestation, there should be, in that time, there should be at least another couple thyroid lab panels ran at that time to really make sure that everything is being monitored well. Now, many doctors don't want to monitor thyroid, and I hear this from patients. They'll say, well, I haven't been trying to get pregnant for more than 6 months, and my doctor says there's no reason to run a thyroid panel. Or, on the flip side, they'll say, well, you're pregnant now, so everything should be fine, and we don't need to worry about running that thyroid panel until later on. I really don't agree with that. And one thing I will put out there is that there was an analysis that was done off of Danish data. So they had collected all this data, and what they found is that with normal, healthy young women, no thyroid abnormalities found, no family history of hypothyroidism, no antibodies tested for, about 10 to 15% of them spiked a TSH over 2.5 once they became pregnant. And that is very problematic. So it's something that I just really want to drive home to you to advocate for yourself and to really make sure that you are having these thyroid labs run. So in addition to that, we also like to look at the free T4, the free T3, and the reverse T3. And I'm not going to spend a whole lot of time on those, but those are just telling us how the thyroid is responding to the signals, is it converting everything well, and it should be part of a panel to really make sure that you're getting the thyroid hormone that you need. What I do want to talk about is the anti-TPO antibodies and the importance of running those. So many people in the Hashimoto's community are aware that anti-TPO antibodies they're the ones that are most commonly come up positive in the case of Hashimoto's. We also see anti-thyroglobulin antibodies being elevated in many cases as well. But anti-TPO antibodies have really been the focus of a lot of research. And what we've come to understand about anti-TPO antibodies. So I first want to explain that antibodies do not equal destruction of your thyroid gland. They tag and flag the thyroid tissue, but that doesn't mean that your immune system actually responds in attacking. So I really like to point that out because elevated antibodies, they don't mean that you're having destruction. They fluctuate all of the time. They can be up one day, down the next day. And lowering your antibodies doesn't necessarily mean that there's no destruction taking place. And, estimates are anywhere from 10 to 40% of Hashimoto's patients actually never test positive for antibodies. And so, that calls us to start looking at things like doing thyroid ultrasounds. But in those patients with anti-TPO antibodies that are elevated, we know there's about a 2 to 3 time increased risk of miscarriage. And on top of being at risk for miscarriage, they're also at risk for preterm delivery, for progressing into postpartum thyroiditis, so an autoimmune thyroid condition, if they didn't already have thyroid destruction taking place prior to conception. And these antibodies can also, you can get cross-reactivity happening on the ovaries, you can get attack on the uterus. And we know that 50% of women who have thyroid antibodies in their first trimester, they will go on to have postpartum thyroiditis. And so I want to talk a little more about that because, these TPO antibodies, they can be they can be an issue with conception, but they can also be a cause of miscarriage. And something really important that I want to point out about miscarriage that is lost in encounters with physicians is that miscarriages can absolutely be a trigger for the development of Hashimoto's. So if you're a woman with elevated TPO antibodies and they don't even have to be that high, and you either miscarry or you have a baby, both of those incidences can actually put you at risk, and they can be a trigger for developing Hashimoto's thyroiditis. And so to understand that a little bit, I think we need to talk about what's going on with the immune system and why this is so important to understand our windows of testing these TPO antibodies. So testing them, I love testing TPO antibodies way before a woman ever wants to conceive, and then keeping track of those. But if you didn't have your TPO antibodies and you're listening to this now and you are pregnant, if you're within your first trimester, you stand the best chance at being able to tell, do you have elevation in these antibodies? Once you are pregnant, your immune system is making a shift. So this is going to be an oversimplification of the immune system, but we have Th1 and we have Th2. Th1 is for our bacteria and viruses, and then Th2 is really supposed to fight parasites, but we see it also developing asthma, allergies, and eczema. Majority of Hashimoto's patients are Th1 dominant. But Th1 is also the part of the immune system that would recognize baby as not being you and attack baby. So your body, being very wise, begins to shift into a Th2 dominant state. So it brings down that Th1 so that you tolerate baby a little bit more. As this happens, those TPO antibodies, we're less likely to catch those. We're not, and most women, they're not going to be detectable at elevated amounts through their pregnancy. However, once you have a baby, that immune system flips and your Th1 comes back online. You also lose your placenta, which was a source of hormones, and that progesterone we know helps in autoimmunity and regulating inflammation. And birth itself is a highly inflammatory state. And so you flip and you move into this situation where it's a perfect storm for autoimmunity, and then you're not sleeping and you're stressed out, and if anyone's listening to this, they're a mom, I'm a mom, and totally know what I'm talking about right now. It's basically the worst thing you can do for your adrenal glands is have a baby. And that's really important to note because your adrenal glands are what are modulating your inflammation, and they're what's keeping that immune system in check. And so when you move into the state where the hormones are dropping, stress is high, you're not sleeping, and you already have the genes set up to develop an autoimmune condition, this can be the triggering event for women. And it's classified as postpartum thyroiditis. And it's not considered Hashimoto's really until you pass that year threshold. And unfortunately, a lot of conventional medicine's approach is just to look at this and say, well, it's a transient state, and if it gets better, fantastic. If it doesn't, then we'll go ahead and give medication as needed. And that's not something that I agree with, and that's not really my approach either. So I want to get into what my approach is and talk about what we do pre-conception and what we're going to be offering as part of my Hashimoto's fertility program that's going to be coming out, and then also talk about how it pertains to pregnancy, and then what we can do looking at postpartum as well. So as most people in the Hashimoto's community understand, it's that gut health is paramount to thyroid health and to immune health. Your gut is going to be the place where you absorb all your nutrients, and it's also a big regulator in your immune system since the majority of your immune system is found there. So pre-conception, we definitely study and work on the microbiome. Your gut health, your microbiome, that's going to become baby's microbiome. So we really want to take a look at that. We want to get rid of any triggers, anything that's growing there that shouldn't be growing there, we want to get rid of, and we want to equally look at what should be growing there and make sure you have adequate gut flora. It's really important that we work on this pre-conception because we want to maximize the nutritional intake during pregnancy, and we want to make sure that you're absorbing all of those things. I also think it's important to identify food sensitivities. I think pretty much everyone on this call probably knows by now, gluten is not something consuming with autoimmune thyroid condition. And that's because it can perpetuate basically the fire that's being created in that thyroid gland. But there can be other food sensitivities as well that are aggravating, and it goes beyond just how your immune system's responding. But in some of the research that's coming out, we can see that if mom is consuming foods that she's sensitive to and she's making antibodies, she can actually pass those food sensitivities on to her baby. Now, I think we need a lot more research in this to understand it, and if anyone's listening to this thinking, oh my gosh, did I give my kid food sensitivities? I'm probably in the same boat as you. So let's just make a pact not to hate on each other or ourselves right now, because that's the worst thing we could do for our immune system. And really, it all comes down to you're doing the best you can with the knowledge you have right now. So in addition to, looking at the microbiome in the gut, we also want to work up women for leaky gut and understand, is there leaky gut? Is there a lack of oral tolerance? And even going further to look if a woman hasn't been on a gluten-free diet, are there celiac antibodies present? Because we know many women with Hashimoto's also suffer from celiac disease, and celiac disease alone can cause infertility. So it's really important that the gut is examined well, especially before pregnancy, because once we get into pregnancy and then breastfeeding, we're a little bit stuck as far as if we need to do antimicrobial treatment, if there's a parasite there. We can't do a whole lot on the antimicrobial layer, but we certainly can build up the gut flora, we can support good gut integrity, and really optimize the gut health. So another area that I like to look at that I already alluded to a bit was the adrenal glands. So I don't think there's a lot of life situations out there that quite match motherhood for the adrenal glands. And if you think about it, you grow this little human inside your body, which is amazing that we do that, and then you go through probably the most fantastic and amazing and challenging athletic event your body's ever been through, and you birth this human into the world. And then you roll into not sleeping and feeling stressed out, and I don't care how many kids that people have had, I hear all the time, they're all different levels of challenge, and it's a different level of stress with having children. And so we really want to optimize mom's adrenal glands before pregnancy. So I like to use things like quality B vitamins, vitamin C, using adaptogenic herbs as necessary. That might look like licorice or rhodiola, maybe ashwagandha if we need to dampen some of the cortisol effects. And we really want to do a good job of building up the adrenal glands and then gently supporting throughout pregnancy, because as I said, there's birth that happens, but going back to what I was talking about before with the inflammation, women who have these elevated TPO antibodies and their adrenals are basically taxed, and they're susceptible to a lot of inflammation, which can actually disrupt serotonin pathways in the brain and can lead to postpartum depression. So for me, from my standpoint, I'm working with numerous women. I really find that adrenal health is paramount and thyroid, but definitely adrenal health is paramount to getting ahead of autoimmunity in that postpartum phase. So we definitely want to support the the ovaries in addition to the adrenals. And I like to think about the ovaries, the adrenals, and the thyroid being like a three-legged stool. And if any one of those legs starts to falter, the whole stool starts to shift. So we have to take into account the ovaries, especially when we're wanting to prep the best egg possible. But the thing I really want to drive home is that you cannot correct an ovarian response. So your brain says FSH, LH, it sends these hormones down to your ovaries to stimulate the development of an egg and the ovulation of an egg. You can't correct that ovaries response if hypothyroidism is not corrected. So if you're working with a practitioner and they're throwing herbs at you and they're giving you bioidentical hormones, they're doing all these things to try to regulate your cycle and help you get pregnant, but the thyroid isn't being addressed, you're not going to get very much traction. So it's really important that thyroid is always being looked at and examined. The nice thing about what we do to optimize egg conception is a lot of that goes hand in hand in what we do to help modulate autoimmunity. And I'll get a little more into different nutrients and supplements here in a few minutes, but it's something that most women come to me and they say, well, what am I going to do about my ovarian health? And the answer is, well, the same thing we're going to do for your overall autoimmune health. So another really big component that I want to touch on briefly before we get into nutrient considerations is the toxins in our environment. I hear often from women who are thinking about having children that they right away stop eating anything that's not organic, which I think is fantastic if you can do that. So they start eating organic food. But, some of the places where things start to, fall apart a little bit is with what is being put on your skin and how your food is being prepared. And there's a lot of little nuances to toxin exposure that has to be taken into account. Now, I want to say we live in a very toxic world, and it is very difficult not to be exposed to toxins every day. And I think it's really easy to get into a panic state when we start to learn about all the different chemicals in our environment and what they can be doing to us. Now, when you walk out of your house every day, you have absolutely no control over if a car passes you and they don't have their smog in check, or if you're going to be going out to a restaurant and maybe things that came back into contact with your food. Like, you have to recognize there's areas where you won't have control. But before you leave your house, that's actually the biggest area where you have control, and also one of the largest environments where we are exposed to toxins. And so what I would really encourage everyone listening to do is to go to the environmentalworkinggroup.org and to check out their Skin Deep and to really examine what you're putting on your skin every day. I think the rule that if you wouldn't put it in your mouth, you shouldn't put it on your skin is a very good one. But I also think it's really important to take a look at what else is in your environment. Now, if you're buying fleece pajamas, they're likely covered in flame retardants. If you're drinking out of plastic water bottles of any kind, I don't care if they say BPA free, they have some kind of plastics in there that are endocrine disruptors. And even something as simple as drinking out of a coffee lid, that acid of the coffee and combine it with the heat, and you liberate BPA right out of that lid. So there's a lot of little nuances in the ways that we can be exposed to toxins. And so I don't ever want patients to feel completely crazy by this, but for them to recognize that there's a lot that we can do in our environment, and then taking little steps and cleaning up your home and making sure your cleaning supplies are the most green possible, and even taking off your shoes before you come in the house, you can make a lot of change in what your body's being exposed to. Now, I just want to touch a little bit on heavy metal testing prior to conception. I think that heavy metal testing is really great to have done prior to conception, but only if you've got greater than a 6-month window until you're planning on becoming pregnant. I have a lot of patients who will come in and they'll say, well, I'd like to be pregnant next month. Ideally, we wait 4 months because it takes 3 months for your egg to mature, and we want to make the best egg possible. But in addition to that, if we liberate these heavy metals and you get pregnant in the next couple months, well, we just took all these heavy metals and put them out into basically, your environment, your ecosystem of your body, and didn't maybe effectively move them out before baby came. And that, I think, is just something, it can be really dangerous to do, and it's important that you do not start detoxifying heavy metals until you make sure that you have good intestinal permeability and you can move those toxins out. So I'm going to grab a sip of tea, and then we're going to talk about nutrient considerations. The most powerful thing I can tell you is that diet and how you live your life every day can have profound outcomes on your fertility, on your pregnancy, and in how you are able to mother. So the first nutrient I want to talk about is vitamin D3. So we're all familiar, with vitamin D. I think that we've done a good job putting it out there that most of us are deficient in vitamin D, and most of us need to supplement with vitamin D. In my Hashimoto's population, my patients, I'm generally, they're supplementing anywhere from 2,000 to 5,000 IUs daily, and this is going to be based on what your lab tests tell us, but that 2,000 to 5,000 is typically followed through the entire pregnancy to make sure that you and baby are getting adequate stores. We definitely want to monitor the levels in pregnancy and during postpartum, but most recommendations now around vitamin D are at about 6,000 IUs daily for breastfeeding women. And that's because that amount of vitamin D is actually going to give baby the vitamin D that they need. But I'm a really big fan of this because vitamin D is going to regulate the immune system, so it helps balance that Th1, Th2 we talked about, and it helps upregulate your T regulatory cells, which put that autoimmunity in check. It's also important for hormone balance. It supports a healthy microbiome, and it's going to help you remineralize your bones. We have a degree of bone density we have to rebuild after having a baby. And vitamin D deficiency is actually associated with postpartum thyroiditis. They found that the more deficient you are, the more likely you are to have that autoimmune flare happen after you deliver. So I also want to talk about selenium and iodine, and I want to talk about them together. So selenium is fantastic in helping lower the TPO antibodies. It's absolutely necessary for synthesizing your thyroid hormone, and most people have come to understand that around 200 micrograms is a good daily dose for selenium. Definitely caution around over-supplementing with selenium. When we over-supplement with any vitamin or mineral, we run the risk of displacing others and causing other deficiencies to take place. So why I want to talk about selenium with iodine is that, iodine is really controversial in the hypothyroid Hashimoto space, and rightly so. I've seen patients who have gone into a full Hashimoto's flare because they were over-supplemented with iodine. And what we know from the research is that in a lot of cases where iodine is a problem, it's actually due to selenium deficiency. So I recommend beginning with selenium and then bringing iodine on board. But it's important to note that iodine needs go up. They're somewhere around like 50% during pregnancy. And so you do need to have iodine during pregnancy, and it's crucial for baby's development. So, even though it's something that it can trigger and it can cause the TPO antibodies to flare, we see that shift in the immune system happening during pregnancy, that the need for iodine is greater than, the potential outcome of flaring those TPO antibodies. And most prenatals these days, they offer you a good amount of iodine, not too high, usually around 150 micrograms, and then they have selenium in there as well, so you have that complement. Now, another nutrient that's worth considering are omega-3 fatty acids. So these come from cold water fish. We typically are using anywhere from 2 to 3 grams daily in preconception, and then we will usually stay with about 2 grams through pregnancy and then bring the dose back up in postpartum. Now, when you're trying to modulate the immune system and decrease inflammation, you want to have a higher level of EPA. But you also need to have DHA available when you're pregnant and while you're breastfeeding, because that is what's going to feed your brain and baby's brain. Now, I talked a little bit about B vitamins before. I think it's better if you have an array of B vitamins, but I want to touch on both B12 and folate. In the lab handout that I told you about that you can download, I talk about the importance of methylation. And so, folate is something, folic acid was put into our food supply, and now we're all discovering that there's many of us with MTHFR variants, which is an enzyme that helps you really utilize your folate. But if you have a defect in this enzyme, the way that it's running, folic acid can actually be like a wrench in your gears. And what's really important to note about this is that many women will be supplementing maybe with folate alone, and that can actually mask a B12 deficiency. And B12 deficiencies are common among Hashimoto's patients and people with low stomach acid. And it's absolutely essential for neurological development and for your own neurological health. So I just want to point those out because I think it's important that B12 and folate be supplemented together and that we make sure that we're testing for B12 in preconception and then even during pregnancy if you weren't tested before you became pregnant. Now, another supplement worth considering is iron. We know that iron is absolutely essential in thyroid hormone production, and it's really easy to become anemic when you're pregnant. I recommend that women have a CBC tested, which is a complete blood count, to screen for anemias. And then we also look at ferritin levels, which is your storage form of iron. The ideal is that we fix your gut ahead of time and we get your hydrochloric acid up to where it should be and your small intestine doing its job and absorbing. But something really simple during pregnancy is that if you are anemic, is pairing your iron with vitamin C and then taking a little bit of apple cider vinegar when you take that supplement to really help you liberate that mineral. Now, I want to talk a little more about a couple of specific things that can really support fertility and support inflammation regulation that are safe to be doing preconception all the way through postpartum. Now, an herb that I think many people are familiar with is turmeric. I love turmeric. And it's really something that can be a simple tea that you make, but the absorption levels can be a little bit low in some of those teas and when you're making it for yourself. But turmeric is, and I should say, so sometimes supplementation is necessary, but turmeric is a fantastic anti-inflammatory. It absolutely is beneficial to gut health, modulating the immune system, and supporting brain health. So I think that's a really important one to point out in moms. And then the last thing that I want to touch on is N-acetylcysteine. And why I want to point this one out, N-acetylcysteine, or NAC, is a precursor to glutathione. And so NAC actually supports the integrity of your ovaries, and it helps decrease oxidative damage that can be taking place. It also aids in liver detoxification, and there have been studies that have shown that 600 milligrams daily, now typically I supplement 600 milligrams 2 to 3 times daily with meals, but 600 milligrams daily has been shown to reduce the incidences of miscarriage. And what they think the reason for that is that we know that NAC reduces inflammatory cytokines. So it's one thing that you can be doing now and during pregnancy and in that postpartum phase to really make sure that you're bringing down your inflammation and you're supporting good oxidative health, so dampening that oxidative stress that occurs. So I know I just shared a whole lot of information, and I tried to cover a lot and make sure that I gave you something actionable. But I want to go ahead and pause and open up for questions.
Dr. Brighton, I just want to give you the heads up because we want to give 15 minutes for question and answer. So do you want to take a couple minutes to close the lecture? And if we have more time and there's not enough questions, we can always come back to you. But I was really present to how much information you wanted to give us, and you're so passionate about the subject. I so appreciate. So you want to take a few minutes to...
Well, actually, I was segueing into asking for questions right then, so your timing is perfect.
Oh, great. Okay. So, Joe, are you all set for the questions coming in?
Sure. Let me just turn on the Q&A mode. And anyone who has a question can hit *6 on their phone to ask a question.
Okay, thank you. I have a question, and I'm not sure if this could be answered in this session, but I'm seeing a reproductive endocrinologist because my husband and I have been trying to get pregnant. I've had a Hashimoto's diagnosis for about 1.5 years, and then probably it's been longer than that. But he wants to switch me from, I'm on Nature's Thyroid and a compounded T3 because I'm not really converting very well, and he wants me to switch over to a synthetic T4 only. And I understood what you said about the T4 crossing or going through the placenta, and that's necessary, but I'm concerned about switching over, and I'm wondering if that's really necessary since there's T4 in the Nature's Thyroid itself.
Thank you for the question. Dr. Brighton?
Yeah, well, the first question I would have is, why are you having poor conversion? And so that's something that I would want to investigate is, where is the issue in converting T4 to T3? Are we looking at an adrenal issue? Is there a lot of stress or cortisol dysregulation? Is there maybe an underlying infection? When we see high levels of reverse T3, which I didn't talk too much about tonight, but that's basically, I call that like the hibernation hormone, because it just grabs onto your thyroid receptors and doesn't let them do much of anything. But when we see that rising, and we see there's an issue with going from T4 to T3, we need to ask ourselves, okay, is there nutrients? Are nutrients at play? Are the adrenals struggling? Or is there some kind of infection? Because the body's trying to signal us that we need to slow down. So that would be my first question, is why is there a conversion issue? And we'd have to look at liver, gut health. That's my approach. We look at the whole person. But the other thing that I hear what you're saying about the nature thyroid and the compounded T3, and you definitely want that compounded T3 so that you feel better. But the reason why that reproductive endocrinologist wants to change you over to a synthetic T4 only is because, what he knows from the research, and the only thing the research is really calling towards, is saying, like, dose with that levothyroxine, give levothyroxine. However, if there's a conversion issue, you're going to definitely struggle as well. I've seen plenty of patients go through pregnancy being on nature thyroid and have absolutely no problem. I've seen combinations where reproductive endocrinologists, they say, well, we really want the levothyroxine on board, and at which point we do a compounded T3. But we have to be careful in pregnancy, because that T3 can be overwhelming to the body and to the tissue. So it's something that it's really tricky when you work with a reproductive endocrinologist, because we so often have to kind of play by their rules, because they're very picky about their regimens and the way that they proceed. But I would try to bring on, another practitioner who can consult on your case and speak to them about, the utilization of maybe a T4 and then a little bit of T3 added in, or maybe staying on the nature thyroid and monitoring the free T4 level. So not just monitoring TSH, but looking at the free T4 hormone as well. And if that's starting to drop below 1, then you might want to employ that synthetic T4. But you also have to be really careful in Hashimoto's patients, because, there's no one medication fits all in Hashimoto's. Some people do great on nature thyroid. Some people are awful on it. I see it more to be true with the synthetic thyroid hormones. And so, they might give you levothyroxine. And what I would recommend is, if you're going to try it, that you try it well in advance of deciding to conceive, like giving yourself at least 3 months to see how you feel. And that doesn't mean stay on it for 3 months. Of course, if you feel awful, you don't want to stay on it, but to give yourself enough of that window to kind of recoup if you don't feel great on that. And so, talking to him about his comfort level of what if you did a compounded, like synthetic T4, added some T3 in, what if you combined it with nature thyroid, or what if you just did the nature thyroid and then monitored the free T4. I hope that makes sense to you in everything that I just said, but I really would encourage you to go back and look at why is there a conversion issue right now.
Thank you for your question. We have another question here from, I think it's Pearl.
Hi, this is Pearl, Dr. Brighton. Everything that you've been sharing has been so educated. I'm just like blown away, and I have like a list of everything to keep looking back at as I move through my pregnancy. I'm in my 3rd trimester, and the thing that you were talking about with the Skin Deep, the website you were discussing, I didn't really grab that from you when you were talking about it, but I'm very interested in what you were talking about with the plastics, and then also everything that you're putting on, your body, like make sure you'd want to put it on your lips as well, or so maybe just reiterating that topic a little bit for me would be helpful.
I'm really glad that you went back to that, because I do feel like I moved to that piece of something that tends to freak people out, and I never want to freak people out. But so I was talking about the environmentalworkinggroup.org/skin Skin Deep. It's a great resource for looking at what's in your skincare products. As women, really one of the highest sources of pollutants that we bring into our body is coming through our personal care products. So it's important to be looking at what are you putting on your skin, looking at your makeup, looking at your hair care products, all of that. I mean, there's times where patients say to me, oh, well, I'm just putting it in my hair, but how many times a day do you touch your hair? And then, it's something, too, that I encourage women to start cleaning all of this up, because then once you have a baby, you're going to be really concerned about the fact that, like, wow, you're nestling baby against your bosom here, and what did you put on that this morning? So, I encourage people to look there. So, what we're looking for endocrine disruptors. We're looking for, and the Environmental Working Group has a great outline of all of this. But we're looking for anything that's going to disrupt the hormones. And then we're also looking at what kind of chemicals are coming in that aggravate the immune system, so that can cause further flares. And then, overall, like, what's going to be a toxic burden to your baby as well. When we're prepping the body for conception, when I approach a woman and she wants to become pregnant, I think of her as both the seed and the soil. So and Papa is totally a part of this as well, but she has the egg, and that will become fertilized. And once it's fertilized, it's inserted into her uterus, which is really the soil, and that baby's going to grow from there. And so we want to think back to, what are we putting on our bodies and what are we exposing ourselves to? What I was talking about, with the BPA, the plastic bottles, I mean, we all in this country got up in arms about BPA, and rightly so. And so they said, fine, we'll take out BPA. And they replaced it with BPS, which is worse than BPA. So they did us no favors with that one. But BPA is showing up in a lot of places. So I was talking about, on your coffee lids, that's a really, really common place for people to miss it. And then drinking out of plastic bottles, you don't know how long that plastic bottle sat in the sun. And the longer it sits in the sun, the more chemicals it leaches into it. And then looking at things like, it's really hard in America. I just want to say that. So I don't want people losing their mind over this. But, even getting a mattress that doesn't have flame retardant in it is really difficult. And we know that Hashimoto's patients, they are susceptible to, these chemicals, and these chemicals can be really problematic for them. And if you think about all these chemicals, they're bad for the autoimmunity, they're bad for your hormones, but they're also bogging down your liver. And your liver's job is to detox what's coming in from the environment and what's in your body, and also to regulate your hormones. And that includes moving out estrogen and converting your thyroid hormone to the active form. And so every time we're exposed to these chemicals, it's just one more burden, one more layer for that liver to have to deal with. So, this is something that I get in really deep, too, with my program, and really making sure that we have the best products in our skin and best products in our house. I hope that answered your question. But this is something I think is absolutely essential, and environmental medicine is really growing to be, more of a standard practice of what we address in the healthcare community.
Thank you. Yeah. No, totally answered.
Thank you. And we have another caller here with a question.
Hi, I was just wondering, what level is something that you would see of a concern for anti-TPO antibodies in the postpartum period? If it's like the anti-TPO antibodies around 10, so they're not lab abnormal, is that still a concern? Would you still try to pull all the stops to prevent it from becoming worse? Or what do you see as like a flag for autoimmune conditions in the postpartum period?
So the question is how far postpartum? Because there's different times in the postpartum period that we can see rises and falls of postpartum. If it's early in 6 to 12 weeks postpartum, which is when I'm typically running thyroid labs and looking at antibodies, and they're low, but they're around 10, I'm going to rerun them again around 6 months, or if symptoms come up. I really want to drive home to all of you listening that you are more than your labs. And that labs are really important, but so is how you feel. And so anytime I look at labs, I'm always correlating it to how the patient feels. I have seen patients with antibodies in the thousands who feel fantastic and have no problem. I've seen patients at 10, I've touched their thyroid, it's boggy, their TSH is elevated, like things are not looking good. And so, it's really subjective. If it's something where, and like I said in the beginning of this call, there's a good percentage of Hashimoto's patients and even postpartum patients whose thyroid antibodies will never be really elevated. 10 is pretty benign and low, but if your TSH, your T4, your T3, and potentially your reverse T3, if all of those numbers are off and you're feeling off and your thyroid is or isn't boggy, it's probably worth getting a thyroid ultrasound and following up with that, because that can be a better way for us to actually visualize what is taking place to the thyroid itself. So, I know it's kind of a long-winded answer to what seems like a simple question, but basically to summarize is that your antibody levels, they don't indicate whether there's necessarily destruction taking place, and just because yours are 10, that doesn't mean that you should feel fine. You could definitely have symptoms and it could be problematic. But the majority, if antibodies are found around 10, that usually is fine. Like 10 is a fine number. It's usually when we start creeping up into the teens that I start to get concerned, and especially when there's symptoms taking place at the same time. But in the postpartum period, if you're having symptoms, I definitely recommend a full workup and test the thyroglobulin antibodies as well, because there's definitely times where that is the only antibody that's rising up and you're not seeing TPO elevation.
Thank you. We have time for one more quick question.
Hi. I was wondering, is there actually a test to see how much your thyroid has been destroyed?
That is a great place for the thyroid ultrasound again. So you can actually look at the tissue that's there. We can also look at those who are not medicated and see what their function is, so we can see how much T4 they're producing and how much T3. But in terms of really understanding how much thyroid destruction there is, that we're usually doing imaging with ultrasound, and then depending on the condition and the case, we may also be doing biopsy, especially if there's nodules found. But in terms of being able to estimate, how much thyroid destruction we have, that's a little more tricky. And something I'll say is that, there's been recent information coming to light that even when there is thyroid destruction, that now the new thought is that we can actually regenerate some of that tissue. So even if there is destruction, it doesn't necessarily mean that your thyroid is completely lost.
Good to know.
Thank you.
Wonderful. Dr. Breiter, thank you so much for all these crucial information that are so important in the well-being of mother and baby. And you wrote a beautiful quote, and I was going to finish with this, but you said it very quickly, and I'm going to repeat it one more time because it's so beautiful, and I just want to leave you all with these beautiful words. And it says, "It is my philosophy that mother is both the seed and the soil to her child." And I want to thank you, everybody, for joining us tonight, and we will be with you again next month. Dr. Breiter, thank you so much for your time.
Thank you very much. It was a pleasure to be here and share.
Thank you.
And I'd just like to say that Hashimoto's Awareness is a nonprofit organization. We rely entirely on the donations of our supporters. So if you'd like to support our cause, please visit our website at hashimotosawareness.org and click on the Donate Heart in the upper right-hand corner. Thank you, everyone, for joining tonight.
Thank you, everyone. Talk to you soon.